Dr. Yineman to talk about her research today. Dr. Yineman did her undergraduate from the South Dakota State University in psychology, and then got her DMD and MPH degrees from ASTO. And then she went out and practiced a little bit in Chandler, but came back to us, and she's currently serving underserved communities as the director of the special care clinic. Thank you so very much, Dr. Yineman, for taking time out to talk to us about your research. And I'll go hand it over to you.
Hi, everyone. Thank you so much, Deb, and thank you to y'all for being here today. Like Deb had mentioned, my name is Sammie Yineman. I'm a general dentist and the assistant director at the special care clinic here at ASDO. I also did my DMD, MPH, and AEGD training here, like she mentioned. And we actually started this study back in 2018 when I was a dental student, and we've continued to fine tune it to present day. So I'm going to go ahead and share my screen here. So Darren, Luana, and myself were all three selected to be in the SRI, the Student Clinician Research Program, which we all utilize to carry out this study. So the title is Dental Student Behavioral Intent Following Exposure to Special Care Dentistry. And a little bit of background information on the topic. Disability impacts every single one of us, whether directly or indirectly. 1 in 4 Americans has a disability, and that equates to about 26% of adults in the US and 61 million total throughout the country. The World Health Organization defines 3 dimensions of disability. The first being impairment of a person's body functions and structures. The next is their activity limitations and their participation in normal daily activities, such as working, engaging in activities, recreational or social, and obtaining healthcare and preventive services. And all of these are impacted by both an individual's environmental and personal factors. So disabilities can be present at birth. They can be developmental, such as autism spectrum disorder, attention deficit disorders, and others. They can be related to an injury, like a traumatic brain injury or a spinal cord injury. They can be a long-standing condition, such as vision, nerve, or limb loss. It can be progressive, like muscular dystrophy or Lou Gehrig's disease, also known as ALS. They can be static, like cerebral palsy or the loss of a limb, or intermittent, like multiple sclerosis. And here is a distribution of the different types of disabilities as defined by the CDC. The most common and what is most often thought of when we talk about a person with disability are issues with getting from A to B or ambulating. So issues with mobility can be a wide range of things. It can be a non-ambulatory individual that uses a motorized wheelchair or a manual wheelchair, or it could be somebody that utilizes a walker just to assist them walking from A to B. The next most common is cognition. So this can also cover a wide range of disorders. It can be a person with IDD or intellectual or delayed development, autism spectrum disorder, attention deficit disorders, traumatic brain injuries, spinal cord injury, or even Alzheimer's or dementia can fit under this category. The hearing and vision are pretty self-explanatory. And then the independent living or issues with self-care, we're seeing this a lot more commonly in the growingly aging population. So most common disabilities, they can hit different demographics differently. So what we see are adults over 65, women, and non-Hispanic American Indians and Alaska Natives tend to see a greater frequency than what we see in the average population. So here's just some data from the CDC that further kind of supports that theory. And so this population still needs to go to their annual wellness visits. They still need to go to their PCP, their optometrist, dermatologist, and the dentist. sorry, I skipped ahead a slide. But this is often a much more difficult task for them. They're often twice as likely to find their provider skills as inadequate. And they're 3 times more likely to be denied care and 4 times more likely to be treated poorly as a result. So they have the same needs as us for the most part, but a lot of times that task is a lot more difficult than it is for the rest of us. So because of all the things mentioned on the previous slide, it's not uncommon to see these individuals who don't even have a PCP, which thereby results in many unmet healthcare needs. As we can see here, 1 in 3, which is a grossly high number, don't have a usual healthcare provider. 1 in 3 have unmet healthcare needs because of cost, and 1 in 4 did not have a routine checkup in the past year. So I'm currently reading this book, and I just came across this quote last night, and I found it to be really powerful and applicable. So I added it in at the last minute. We uphold a system of ableism, where able-bodied people are the default body, and the world is constructed to best serve them at the expense of disabled people. But shouldn't it be the other way around? With an increasing number of people who fit in the disabled category, shouldn't us able bodies be the ones making the accommodations? Fortunately, I'm hopeful that we'll continue achieving small steps in the right direction towards making life easier for this population. As most of us know, the Americans with Disabilities Act was passed in 1990 that outlawed discrimination of disabled people, and it continues getting amended as more data is released and different scenarios arrive. So we're hoping to see a continued positive trend in accommodations for this population. So how does this apply to us as dentists? Well, there are an increasing number of patients with special healthcare needs and a lack of providers who are able and willing to treat them. A majority of general dentists report a lack of knowledge, skills, and experience in treating patients with disabilities and those from marginalized groups. For this study, we utilize the theory of planned behavior, which is a psychological construct that implies a combination of people's attitudes, subjective norms, perceived behavioral control, can thereby predict their intentions, and is thus an indicator of what their future behavior will be. And the IADH and Dr. Denise Fox developed a series of surveys that we call the IADH Toolkit that utilizes the theory of planned behavior and is intended to evaluate the attitudes and the intentions of dental students in treating patients with special healthcare needs. So a little bit more on that theory. It is utilized to explain a person's intended behavior based on their ability to exert self-control in the situation, and it assumes that their behavioral intentions are based on their assessment of the risks and the benefits of the outcome and the likelihood that their predicted outcome will match the actual result. So that sounds a little bit confusing, but basically you can think of it as the attitudes and values, beliefs of what is normal or expected of them by others, and their perception of how much control they have over their own actions influence their behavioral intentions and thereby predicts their future behavior. So this is a nice little chart that kind of outlines that in a little bit more simplistic form. So the questionnaire has been used worldwide. The toolbox, as we referred to earlier, it's been progressively modified over time in order to be as accurate, valid, and repeatable as possible. In its current form, it has been administered to dental students all throughout Malaysia, Ireland, Canada, England, and now in the United States, and also many other countries. So Dr. Fox had created the toolkit, for which parts of it have been validated by other academic institutions. It consists of 6 domains: beliefs, values, subjective norms, normative beliefs, the motivation to comply, and the perceived behavioral control. And this is accompanied with a theoretical scenario that students score on a Likert scale. And I'll dive into a little bit more detail of that in just a minute here. So the purpose of this study is to evaluate the intended behavior of dental students and their willingness to treat patients with special healthcare needs at various points in their dental school curriculum after exposure to both didactic and clinical special care dentistry. Modifications in dental education curricula may increase the likelihood of a graduate's willingness to treat patients with special needs and thereby improve access to dental care for this population by creating more people who are able and willing to treat. So our hypothesis is that exposure to special care dentistry in both clinical and didactic environments will positively alter a dental student's behavioral intent to treat patients with special needs after graduation. And if you look really close, this is actually me as a baby D3 at our Day for Special Smiles event. I think that would have been back in 2018. And then this is Alicia Kennedy, who was class of 2021. So our sample population was the ASDO class of 2020. They were surveyed at 4 different points in their curriculum during their second semester of their D2 year prior to any exposure at all. And then after the didactic course, in which they spent 2 weeks learning about different disabilities. They do disability simulations where they wear glasses that simulate what someone who's visually impaired can see. They wear weighted arms and legs and limbs to see what it's like to try to move around. They use a wheelchair and they try to get from A to B on campus. And they also spend some time at the different group homes or activity centers with different people with special needs, and they just play dodgeball, they do puzzles, and they just do fun things to kind of get to know them on a level that's not patient doctor based. It's more person to person. And then they're surveyed again 2 times in their D4 year. The first semester after they've done 2-week-long clinical rotations in our clinic as D3s, and then at the end of their 4th year when they've done a total of 4 years of clinical rotation among their D3 and D4 year. So there were no exclusion criteria. The only inclusion criteria was being a dental student in the class of 2020 here at ASDO. So from the toolkit, we utilized questionnaire 4 with scenario 2 that was administered electronically and anonymously to 73 dental students at the 4 different points mentioned previously. And this was administered via both Qualtrics and Google Forms. It consists of 9 total questions, and we applied the theory of planned behavior, which was discussed previously, and this constitutes the belief that their attitudes influence their behavioral intentions. ANOVA was then utilized to compare the scores across the 6 scales at the 4 different time points. So our independent variable was the amount of exposure that they've had to special care dentistry, and the dependent was their individual's behavioral intent that they reported in their survey. So here's an example of the scenario question. After we acquire some basic demographic information from the participant, the survey asks about their previous work and relationships with people with disabilities and of marginalized groups, because sometimes that can create somewhat of a bias if they have a family member or if they're already relatively familiar with working with this population. And then it dives into a hypothetical scenario followed by different Likert scales that list the likelihood for each listed scenario. So the question reads as follows. You receive a phone call from the caregiver of an adult with Down syndrome living in sheltered housing. She says that the patient has lost a restoration on an upper front tooth. Assuming that the treatment required was within your clinical competence, would you provide care for this patient? Yes or no? And then each of the questions kind of build off of that first question. So how difficult was it for you to make this decision? Again, on a Likert scale, 1 to 7, you'll see across the board for consistency, that was the method that was utilized. So 1 being not difficult at all, with 7 being extremely difficult. And then 3 is where we start to get into the norms and the different constructs of the study. So it would take too long. It would make the patient anxious. I'd not be able to provide quality care. It would disrupt the organization of my practice. I'd not be able to communicate effectively. It would make me anxious as the provider, or it would not be safe for me and my team. And they ranked it as 1, extremely likely as 1, or extremely unlikely as 7. So question number 4 touches on the values construct. So the following outcomes would be as such, with 1 being extremely important and 7 being extremely unimportant. So taking too long over treatment, making the patient anxious, managing to provide quality care, not disrupting the organization of the practice, being able to communicate effectively, not making the dentist anxious, or keeping the dentist and the dental team safe. And then they ranked each of those based on what's most important to them. And they weren't required to go, rank each 1 through 7. They just could pick a random value for each question. And then the subjective norms for question 5. So this kind of has to do with what the student or the individual feels is expected of them by those around them. So the people who are important to me would expect me to treat this patient. Legally, I need to treat this patient. Other dentists, my colleagues, I would feel under social pressure to treat this patient. This patient would expect me to treat him or her, or my other patients would expect me to treat this patient. And then into our normative beliefs construct, again, a Likert scale, 1 with strongly disagree, 7 strongly agree. Most people who are important to me think I should. Legislation obliges me to treat this patient. Other dentists, my colleagues, society, other patients, or this particular patient thinks that I should treat him or her. And next is the motivation to comply. So this has to do with how much do they comply to what the people around them expect them or think that they should do. The approval of people close to me is important. My legal obligation is important. The approval of other dentists, my colleagues, society, other patients, or this particular patient is important to me. And then the last 2 questions is their perceived behavioral control. So it would be easy for me to treat this patient. I'm confident that I could. The decision to treat this patient is mine and mine alone. There are no factors beyond my control that affect my decision to treat this patient. I have sufficient experience to do so. And then lastly are just the other factors that could play into making this decision, which is not working at a loss, not feeling rushed, not making my regular patients wait longer, or having to modify my usual techniques, and having adequate training in order to do so. So here are the 4 domains that this is based off of. Questions 3 and 4 deal more with behavioral outcome beliefs and the individual's outcome evaluation. This allows the individual to assess the pros and cons of the situation as they attempt to place value on each of those points that were listed previously. The subjective norms, which involve questions 5 and 6. What is expected of you by others and what do they think you should do? And then the motivation to comply. So like we touched on earlier, how much does what expected of others and what they think you should do influence what you're actually going to do? And how much do you really care about the approval of all of the people that were listed? And then lastly, is there perceived control over their own behavior? So how much control do they think they have over the situation? And how much do they think that their decision would change if those uncontrolled variables are controlled? So we said that this was evaluated on a 7-point Likert scale. Our subject number was 73 dental students in the class of 2020, and these constructs were sorted into the 6 domains: beliefs, attitudes, subjective norms, normative beliefs, the motivation to comply, and their perceived behavioral control. Question 1 was reported as a yes or no, while the remainder questions 2 through 9 were reported as mean standard deviation, and ANOVA was utilized to compare the scores across each of the 6 domains. So we took the Likert rankings and then we plugged them into a different equation, whereas numbers 1 through 3 ranked as negative values, number 4 was neutral, and 5 through 7 had positive 1, 2, and 3. And then each of those were analyzed across ANOVA, and that's how we came up with our results. And we found that statistically significant differences were noted across both beliefs and perceived behavioral control. So therefore, both the decision and the confidence to provide care were made easier after the dental students' exposure to special care dentistry. In general, students felt that they had sufficient experience to treat this patient, and that doing so would not disrupt or hinder their clinical performance. So prior to any exposure at all, 97% of the respondents answered yes to question 1, that they would treat this patient. This is before they've had any didactic course or any clinical training. So we may have already started with somewhat of a biased sample. After their exposure to didactic training, this was when they had all their fun. They did puzzles, they played dodgeball, they went to the activity center and they hung out with the patients person to person. That one person changed their mind, and then the overall total increased to 100% yes of respondents. But then after 1 year of clinical training, we found that the data actually dropped to 80%. And then again, after that additional 2 weeks at the end of their D4 year, one person changed their mind and it went up to 83%. So here is that data indicated on a graph. I'm hoping you guys can read these small numbers. I wasn't able to make them bigger, but you have the pre-didactic values, post-didactic, and then after their 2 1-week clinical rotations, and then after 4 in total, because they do 2 1-week long rotations D3 year, and then 2 1-week long rotations their D4 year. So what happened to the other 20% is really unknown, because no follow-up was able to be done, given that the surveys were all anonymous. So we weren't able to pick out those no respondents and then and ask them, why did you change your mind? Because we had to keep the survey anonymous. But we can infer that increased exposure to special care dentistry in a dental school leads to a greater confidence and abilities and less hindrance in their clinical performance to treat patients with special healthcare needs after graduation. We can accept our original hypothesis because by the end of D4 year, we did have over 80% of the class that was willing to treat the sample patient or the hypothetical patient that was given in the questionnaire. It could perhaps be theorized that after exposure to the special needs didactic course, students had a much more altruistic mindset as to who they would treat, and getting to know patients of this population on a more personal level just gave them an overall much more positive mindset. And it could be that when they're in a dental clinical setting, they're a new provider that's learning a new skill in general, and then combining that with seeing a new population that they may or may not have interacted with much can evoke a sense of being overwhelmed, which could be a potential explanation for the negative behavior change in the small percentage. But again, we can't really say for sure based on the nature of the study. So we've been continuing this approach to students training, and we've graduated many dentists who are actively involved in treating patients with disabilities and special needs. D4 students will go on rotation to external sites, and I have them come back and tell me that they saw patients with ASD or other disorders or disabilities that their attending preceptors or the doctors overseeing them on these rotations don't feel comfortable treating. And it could be too, it should be noted that there is a potential bias in our study, given that ASDO has many students who already possess an inclination for treating this population and for special care dentistry. So many do seek out our school because of that. So that should just be noted. And I wanted to give a special thanks to Dr. Ann Spolarich, Dr. Kurt Bay, all of our ASDO special care dentistry faculty and staff. That's my work family. We're working day in and day out treating these patients. The IADH and Dr. Denise Fox, and the AT Still Research Institute for providing the funding to allow this opportunity to be possible. Here are just a few additional references, and thank you all so much for your time. And now I wanted to open it up for any questions from the group. I'm going to go ahead and stop my screen share here. Dr. Perry, I can see you're on.
I can see you, Dr. Yineman. Excellent presentation. I just wanted to mention to the group that this was part of our educational evaluation to see whether we're making a difference. So that's important to note, that that's the reason we got such a high response rate. So we actually do this as part of our course to evaluate whether or not we're making a difference, because there have been prior studies where when people, when dental students were exposed to other kinds of what we would call quote unquote marginalized groups, they basically met different kinds of people and said, no thanks, I never want to do this again. So that was one of the reasons for trying this, to see, does this increase? Now, it would be great if we knew if it happens in real life, and honestly, we only know anecdotally, right? We know it worked for you. Let's see, it worked for you, Dr. Miley, Dr. Howell. We know we've converted a few of you, but we do know that there are people out doing this. So I thank you for your presentation. It's wonderful, and I look forward to when you write this up.
Thank you very much. It was a pleasure to work on it with you.
Thank you, Dr. Yineman. That was wonderful. And I always wondered why the dental students walk around in wheelchairs and wear those weighted glasses. And I was like, what's going on? Some kind of simulation, but this clears it up all up. Such a great purpose. I have one question around methodology, but I don't know if it's something that you are responsible for. I'm just wondering to the scales, like why choose a 7 scale questionnaire instead of a 5 scale for the scaled questions? You had like a 7 scale.
Yeah, good question. It more had to do with the way that the toolkit was already formed by the IADH and Dr. Denise Fox, because there needs to be consistency across all of the different surveys and that they're doing, they all utilize the 7-point. So I can't speak to why it was originally written with a 7 or 5-point, but we had to adhere to what the other surveys were doing just to make sure there were consistency across the data on all fronts. Maybe Dr. Splarit or Dr. Perry can add on to that a little bit.
Dr. Perry, I mean, I know that this part of this too, one of the reasons why ASDO adopted testing the toolkit was that Denise Fox was actually looking for programs throughout the world to take the toolkit and to do validation activities, because this is a way to promote some universality across training. And of course, obviously we have cultural differences in different countries and training requirements are different. And I remember after we got this data set, one of the things we were thinking about is, did we really help the cause? Because we know that our school, as Dr. Yineman said, really has a penchant towards this area. And we know there are students who specifically seek out ASDO to come here. So, we asked ourselves this question of, did we potentially bias the results because of who we are as an institution? Dr. Perry, did you want to add to that?
Well, I would say that, yeah, we just have to mention that, but like, that's okay, right? Like we found a good way to funnel people to want to do special care dentistry. And maybe, other schools wouldn't have the same results because they're not looking for those same kinds of people at the beginning. So maybe it says that if you want to create, somebody who wants this, you have to start at a pipeline. Like, this is not somebody who just wakes up in dental school and decides, yeah, hey, and I think there are people that do that, but I think we also have a large percentage of people who don't. I think the significance of this is sharing with people that if you do this, you get that, right? So this is important because since it's a new CODA regulation has been upped for pre-doc, right? So people have to manage, and there's been a flurry of activity of dental schools making programs, looking for directors, building clinics. So I think this is important to say, hey, if you do it, you can be successful. So I think that's the importance of this particular research in saying you can actually do this at home, right? It's like, try this, you can do this at home, and encouraging people that you can be successful, and it's not insignificant, right? It's not a waste of curricular time. And I think that's sometimes the challenge.
I think the nice thing too is, as different schools do this in different parts of the world, we'll create this very unique body of literature. in support, hopefully, of the toolkit, that different approaches, different training programs, different cultural influences will still come out in the end, that having this experience and training really helps to promote adoption and a willingness to provide care to these individuals later in once they get out of school. And that really is the next study, is that can you track those people, those graduates, and find out how many actually are doing so in practice. It's a little tough to track that cohort, but they tend to stay in the family, if you will. We tend to kind of know, we kind of affectionately call them our mascots, the ones who really really stay specifically working in this type of domain. But we have had similar results that we published out of ASDO this summer with the training dental hygiene students, a kind of a not using this particular tool, but a similar model of having didactic and clinical exposure, and how does that change their comfort and willingness to treat this population. And we actually had even higher numbers because a lot of those students really didn't have a lot of exposure or experience, and having that hands-on experience is what really changed the discussion and attitudes.
Yeah, you'll note that the hands-on experience changes the students' attitudes, because in the beginning they're so eager, and then when the reality of how difficult this is, they're like, wait a second, right? And then it sort of turns back at the end after they have more clinical experience. It sort of turns back up after their D4s, and they go, oh, okay, I can do this. But I think D3 clinical rotations is sort of their reality check. It's like, whoa, okay, bit off more than I can chew. Which I think is also a really good lesson to share with people, that you may not get a positive reaction the first time, that people really have to be sort of embedded in this and supported as they do this, because the first time can be a bit scary for some people, right? It can be very intimidating, and people can feel very challenged when they don't have great clinical skills. They haven't mastered things. But by the time they master it, they're like, oh, hey, this is okay, right? So I think discussing that and telling people who are starting programs that this is okay, this is an expectation. And that was an important finding, and one that we weren't looking for, by the way.
Yeah. Yeah, and it's very interesting. Like I really appreciated your comment, Dr. Yineman, too, about how when our D4s go out on rotation, they're the ones who are willing to treat the patients. With some of the people who work in those clinics are like, yeah, we don't really have the comfort zone to do that. And our students are like, yeah, all in a day's work, which is a great
Yeah.
thing.
It just further attests that exposure creates familiarity, and then eventually a sense of comfortableness. And so that's our goal overall, is to create more providers who can treat this population, and then also increase their access to care by creating more providers who would qualify to treat them. Any other questions? I appreciate the good questions.
I have another question. Sorry, I'm hogging all the time, but there's so
No,
many.
that's great.
It's just so interesting about this. How do you, I don't know, it's not in the purview of this research topic, but how do you connect the patients to the providers? Because some of these patients might not have access, like in terms of advocates or insurance, or even the worldview of seeking dental care, and also infrastructure. If I'm wondering if there's specialized infrastructure required to take care of special needs populations.
So a lot of that has to do with just the training of the individual, and it differs state by state too. We are kind of the primary resource and the connector within our community. And we know that if we can't treat them, we know who we need to send them to within the community, because there is such a need, especially for those patients who need hospitalized dentistry, or really medically complex patients. that we can't sedate here because we are located on a second floor and all of our sedation treatment is done in the dental chair. So we have a lot of restrictions in that regard of if we have a bariatric patient who cannot be seen in the standard dental chair, we need to refer them to a hospital setting. We have patients who we treat in gurneys, and that's not somebody who can be seen for sedation on a second floor dental clinic because say something catastrophic were to happen while the patient's under, like the building sets on fire or something. How are we going to transfer that patient and get them downstairs in a feasible manner of time? So it is challenging to find people, and most of that it comes with getting connected with the special care network within the community. So places like Special Olympics, we're doing a lot of outreach, and then usually they can refer you to the appropriate people. Maybe Dr. Perry has a comment on that as well.
Well, I will say this, one of our students many, many years ago worked with me and with Special Care Dentistry Association, which is the national organization for people that do what we do. And one of the things that they did was start a directory of dentists across the state so that dentists and patients could look up in their state and say, I live in this zip code. Is there someone who's a special care dentist in my zip code? And now it's much more sophisticated. When we did it, it was like 15 years ago. It was not a sophisticated survey. It was actually a paper survey. It took a lot of data entry and a lot of time. But now we have a pretty good network. And so if you Google like special care dentist, that will come up and people can find it. We also work a lot of the organizations and a lot of the special care dentists in America will join with their DDPC, the Developmental Disabilities Planning Committee. So in every state this exists, it's federally funded. And that group usually connects providers and patients. The DDPCs, they always have providers on their council, but they also have a lot of advocates. It's really self-driven by people with disabilities. So that's a really important part of the infrastructure that not a lot of people know about.
Thank you, Dr. Perry.
Dr. Yineman, this is entirely outside the purview of your project, but I'm just wondering if you have any sense of or knowledge of other people seeing whether other places seeing whether this kind of experiment, this kind of exposure also holds true for other underserved populations, generationally poor or immigrant populations of low education and low English availability, that kind of thing. Do you have any sense of whether exposure to those populations in a clinic setting during training increases willingness to then go out in the community and serve those individuals?
So the toolkit, the question that we used was directly specific to a patient with Down syndrome, but there are other scenarios in the toolkit that specify more to marginalized groups. I have not seen that data personally, but again, I may have to defer to my mentor, Dr. Perry, in this situation, or Dr. Spolarish to see if they've seen any kind of data, because it is out there and the toolkit does encompass some of those questions for marginalized groups.
Okay, thank you.
I do know that there are some other schools that are doing really interesting work with their students, where they are exposing them to very specific groups, refugees, for example, Holocaust survivors. There are pockets of interesting work that are kind of in progress right now at different dental schools, and they are doing a lot of the work actually in the field, as opposed to having those individuals come into the clinic, where they're going out to community health centers or centers that are tailored to address the needs of those very specific groups. You see that a lot in back east in some of those schools, some of the major cities. So I know that some of that work is going on.
But it brings up a great idea, because we send our students into community health centers. It would be a really interesting thing to run this sort of, educational evaluation. Like what is the difference? Because many schools have followed in ASDO's footsteps to do community-based learning, right? So the question is, does that actually change what people want to do with other kinds of marginalized groups? And I have not seen a whole lot of data with that. Some smaller groups, but not a whole lot of data.
Yeah, we have some data, as does Colorado, on putting students into those safety net clinics and a increase in their placement and desire to work in those locations, but it's not necessarily focused on certain marginalized populations. But that would be really interesting as well for us to look at that next kind of step. Okay, we know that we can recruit, train, and help students' interest in going into those types of clinics. Now, how about, how does that work for certain populations? I believe 40 of our 41 American Indian graduate dentists have all gone back to tribal clinics or IHS clinic sites as an example of some of the data we've seen too. So
Thank you.
I can also tell you, Catherine, right now, ASDO is in the process, literally just went live yesterday. We are participating as a school that's part of a larger environmental scan that is looking at what are the curriculum needs and perceptions of faculty in how well we're preparing our students to care for LGBTQ plus patients, and where are the gaps and what are the issues, and part of that is the national group that we're collaborating with is in the process of trying to develop some curriculum standards. And again, I think a lot of this is like, I won't call it a toolkit yet, but it may be leading to something like that, where lots of schools could adopt that and try to implement it in the curriculum. So everybody's not recreating the wheel, that you have these kinds of standardized types of approaches to education, and that allows for better study, right? If you have somebody who's trying to approach it in a very systematic way.
This all sounds wonderful. I should introduce myself, by the way. I'm new to sponsored programs. I'm doing special grant initiatives. So if any of you get to the point, or a group of you get to the point where you're thinking of, well, let's pursue a project, feel free to reach out. So I would be very interested in helping you with this.
Thanks, Catherine. Welcome aboard.
That would be great. We might have to do part 2 with our toolkit on our
Yep.
students going out on rotation.
Indeed.
Mm-hmm.
Dr. Jackson, I just wanted to take this opportunity to also let everybody know that Dr. Yineman, you heard in her introduction, is a product of ASDO, and I feel very blessed to be sitting here in a full circle moment, because having had Dr. Yineman as a student and then as a resident, and knowing she was one of our Still Research Institute members of our student clinician researcher development program. And she really, you can see this is like a full circle moment, because this is exactly the intention of that program, is that we socialize students to a value and desire for clinical research. And now we get to have her back, and I have this wonderful moment to get to teach alongside of her in the clinic, and it's such a terrific, great opportunity. And we appreciate the Institute giving Dr. Yineman this moment to kind of share and illustrate the work that she did. And I'm already working on her with what the next studies are going to be. So it's great. And so thanks, Dr. Yineman, for being such a great product of that program.
Well, thank you so much. A lot of my mentors are on this Zoom, so I have to call out Dr. Sklarich, Dr. Perry, Miss Ellen, Dr. Miley. They all kind of trained me to be the baby provider that I am today. And we always joke that I drank the special care Kool-Aid, and once you drink it, you don't go back. So now it's a passion of mine too. And I'm just lucky to work alongside such a stellar team and be at the place that raised me. So thank you to all of you.
Oh, well, it's just beautiful. And I really appreciate your presentation today. And it's really, it just brings so much joy just to watch you, you know, grow up here and then just shine and go forth and help so many people. So it's really, thank you so much for presenting to us today and sharing your work and what you're thinking for the future.
Well, thank you so much. It's really an honor of mine. So, and I appreciate the support from every single one of you and the Still Research Institute. Couldn't have done it without all of you. So it's my pleasure, truly.
Well, we're so proud of you. All right. Any other comments, questions? All right. Well, we'll give you about 15 minutes back in your day. Thank you so much. It was an awesome 45 minutes, and you all take care. And if we don't talk to you, wishing you a wonderful holiday season and a great winter break.
Happy holidays.
Bye.
Happy holidays. Thank you, everyone.
Thank you.